So in this last section, talking about neuromuscular electrical stimulation, we are going to specifically talk about kind of that last indication, or the last two indications, using neuromuscular electrical stim for motor control and edema reduction. So the learning objectives for this section are to describe the elements of implementing a treatment for stroke or spinal cord injury with electrical stim, what waveform options there are, the stimulus settings for achieving an adequate dose of stimulus. I want you to be able to describe the elements of implementing a treatment for edema with electrical stim. And patient positioning is a consideration with edema as well. And I want you to be able to identify some outcome measures that you might use for these type of treatments. So when we're using e-stim for pain management, we are looking at pain a little bit and what was their pain before and after, but that can't be our only outcome measure. We need functional outcome measures. And when we're doing it for strength or edema reduction, functional outcome measures are the gold standard. That's what we need to do. We're trying to improve their function. So we're going to talk about some outcome measures that we might use to show that we are improving function. So again, the indications we talked about before: increasing muscle strength, enhancing performance in healthy muscle, improving muscle endurance, facilitating range of motion, modifying spasticity. So it can, you might be doing muscle strengthening for orthopedic conditions. You might be doing cardiorespiratory or functional training in certain patient populations, like people who have spinal cord injuries or MS or diminished muscle function for some reason. They might be, we might be doing functional, like a functional electrical stim bike or rowing machine, to improve their cardiorespiratory function. For doing muscle strengthening in healthy adults and athletes, we talked about this in the last section. Improved muscle coordination and motor control for neurological conditions. Edema control and improved circulation. If you don't have good movement or good range of motion, you might have edema in that limb, and so getting some movement going to reduce or control edema. And to retard atrophy and encourage return of function in denervated muscle, either from a spinal cord injury or some other neurological injury. So these are some synergy patterns that you might see in people with different neurological injuries, and we're going to use electrical stim to counteract those synergy positions. So to enhance motor control with functional electrical stimulation, really the difference between this and NMES is that we are trying to facilitate purposeful movement. So in clients with central nervous system impairments, we want to provide sensory cues. So we're stimulating sensory nerves and motor nerves. So we're trying, because there is a sensory motor feedback system that has to do with movement, and we'll talk more about this in neurology, but we want to provide those sensory cues to guide movement. We want to activate muscles in a functional pattern. We want to complete a weak motor function, so you might have foot drop from weak dorsiflexors, and we're going to stim the dorsiflexors to complete that motor function. We want to teach timing and sequencing and activation of muscles in a functional pattern, and optimize voluntary control of motor function. So this type of stimulus, if you have peripheral nervous system pathology, you are not going to be using functional electrical stim, usually. This is usually for people with central nervous system pathology. So improving muscle coordination and motor control for neurological conditions, this can be integrated with the performance of functional activities. And so basically what functional electrical stim is doing is stimulating intact peripheral nerves in patients with central nervous system damage. So in the picture, the guy is using a functional electrical stim on a rowing machine, which helps coordinate those functional movements. You're stimulating their intact peripheral nerves to create the movement. So they still have the peripheral nervous system to do it, but the central nervous system is what's missing in spinal cord, stroke, MS, TBI, CP, lots of different CNS damage. So when you're doing it specifically for stroke, you can use lower extremity stimulation to improve gait, to increase ankle dorsiflexion torque, and to reduce agonist-antagonist co-contraction with synergy patterns. And a lot of times you can increase their probability of returning home independently using this electrical stimulation. So there is EMG triggered NMES, so you might have a motion that triggers the electrical stim. In the case of the picture here, it's someone who has an FES device to stimulate dorsiflexors to improve her gait. That antagonist contraction reduces agonist spasticity. Agonist contraction can increase agonist strength and control. So you can have lots of different reasons for using NMES after someone's had a stroke. And I've actually worked with several patients who were fitted for these functional electrical stim dorsiflexion devices, and it drastically improved their gait. Of course, they had to do 6 months to a year of PT before they were at the right stage to use these devices, but it's really nice to see this in action. For spinal cord injury, a lot of times what you're doing is you're not going to bring back their function entirely, but you're trying to counteract disuse muscle atrophy. You're trying to improve circulation, contract the muscle to assist with locomotion, perhaps, not in everybody, and you're trying to contract muscle to assist with hand grasp, respiration, conditioning, and bowel and bladder voiding. So obviously those are all specific functional treatments. A lot of times in my clinic what we use is functional electrical stim bike to improve circulation and counteract disuse atrophy. Usually you have to be able to stim them with a sufficient force to carry out the activity, and it can't be painful. The good thing about it is it can be controlled and repeated, and it's usually an acceptable activity for the end user. So if you get a chance to get hooked up to an electrical stim bike, do it, because it's nice to know how it feels. It's not comfortable, and it's not easy. It does take, so you have to build up some tolerance to it. But once you build up tolerance to it, it is a really great intervention. And a lot of people can get prescribed a functional electrical stim bike or rowing machine for home use, so they can use it on a regular basis. In my clinic, we have a community program for people with neurological conditions. They can come in and use our functional bike. They have appointment times that they do it, and so they can have that repeated and progressive use of functional electrical stim. So really what you want to do is you want to identify the motor impairment. So the PT has to evaluate and identify that motor impairment. It might be weakness, it might be inadequate recruitment despite adequate strength, so that might be that sensory portion of it. Timing, sequencing, motor planning, and execution. You want to identify 1 or 2 muscle groups that are implicated for treatment, and the outcome has to incorporate function to make it functional electrical stim. So you're focusing on the activity, so you're focusing on gait, or you're focusing on another functional activity that person can participate in. In the upper extremity, people with CVA and who have a limited hand function, they can use an electrical stim device that can improve their wrist and hand function. It can be coupled with the electromyographic device or positional feedback. The nice thing is it can help them, these type of devices can help people perform a functional task, but it doesn't necessarily make the function come back. So it's a device that allows them to perform a task. So a lot of the studies in terms of clinical efficacy, there are other treatments besides these electrical stim devices that help them return to function. And so either they didn't evaluate in the studies, they didn't evaluate the long-term recovery, or it wasn't statistically different from traditional therapy without NMES. So it's just another option out there for treatment. Those dorsiflexion devices, they facilitate dorsiflexion during gait from the heel lift through the swing phase to the heel strike. So that's with a heel switch. Or they can facilitate quadriceps or hamstrings for stability and weight bearing during the stance. Usually these devices improve cadence, velocity, stride length, and balance, or that's what's been shown in the studies. So what you want to consider with interventions is you want to identify an activity within which motor control goal may be targeted, like dorsiflexion in the gait cycle or the timing of a contraction for grasp and release activity. The frequency is, you want to produce muscle tetany, again, so it's going to be 30 to 40 pulses per second depending on the size of the muscle group. The pulse duration has to stimulate motor axons and minimize pain, so we're in that sweet spot where we're not getting the A delta fibers as much. The treatment has to be short in duration. Fatigue is usually less of an issue because we're doing a functional activity. You don't do a functional activity till you drop most of the time. You just do it till you get it done. And a lot of these devices have a remote switch or a programmable device to trigger the contraction for timing in a functional activity like a heel switch or a hand switch. When we're assessing outcomes, we want to have outcome measures that show functional improvement tied to improvement in impairments. So the impairments can be in range of motion, force, timing, independence, balance, efficiency, walking speed, energy cost, leading to improved function, and participation. So two of the standard outcome measures that can be used are the time to up and go test, which is pictured here. You have a cone, a person sitting in a chair, a cone that is 3 meters away, and you time them and the amount of time it takes to stand up, walk 3 meters, turn around, walk back, and sit down. On the 6-minute walk test, you see how far they can walk in 6 minutes. So obviously those are relevant for day-to-day things. A lot of times when you're going to assess the outcome measure at the beginning, and you're not going to assess it every time you see them. You're going to allow a 1 to 2 week trial of a device or an intervention before you retest them. So it's not like you test them at the beginning of the session, at the end of the session, and see that they improve. They have to have time to incorporate those improvements. For people with CVA, their potential for improvement may change over time. So sometimes I've had people with either peripheral demyelination diseases like Guillain-Barré syndrome or with a CVA where their potential is changing over time. You tried an electrical stim device with them once, it didn't work. You might try it again later after some time has elapsed. So, and then it might work great. So I've had people like doing neuromuscular electrical stim for dorsiflexion. The first time we tried it, it didn't work at all. We could not get a good dorsiflexion contraction. But then a few weeks later or a few months later, we tried it again and it worked great. So you might periodically offer a trial of that device. You go, okay, well, it didn't work last time, but let's try it again. Now that you've had more time to heal and incorporate these challenges into your life. And so think about that. If something it doesn't always work. Sometimes if it doesn't work, try it again in a couple weeks or a couple months and see if it works better. So orthotic assist for clients with CVA, there are orthotics that facilitate wrist and finger extension to prepare for grasp. Some of them are motion triggered. They have external electrodes, and a slight wrist extension can trigger the stimulus for finger extension. It provides functional assistance but not functional independence. In other words, it allows them to do the functional activity when they have the orthotic assist device on, but they can't do it without the device, if that makes sense. The dorsiflexion assist walking systems, they can actually be comparable to wearing an AFO and facilitating gait with dorsiflexion. So there's usually a small leg cuff that's worn below the knee, and it contains electrodes that are placed on target areas, and they're determined for an individual patient. There's a heel sensor in the shoe that determines the heel strike phase of gait, and a wireless remote control unit that adjusts the level of stim. And these days, the newer devices, the control unit can be on your smartphone. So they can use the app on their smartphone to turn up the stim, which is really cool. And the software program determines other components of gait and is downloaded to the wireless remote. So basically, this orthotic assist replaces a passive AFO for dorsiflexion. So, I mean, that's a reason for using it, is you have an active device that's stimming the muscles rather than a passive device that's physically lifting your toes up. So this is two people walking with those functional devices, and they're pretty cool. And I love watching the difference between someone. I had someone recently who had one of these, and I had her walking on the treadmill with the device and without the device, and we did video gait analysis with and without, and it was amazing. And the limitation to her using it when she first got it was fatigue. So when she started to fatigue, it was difficult to use the device, and so she had to take a rest from it. But as she used it, she was able to go longer without fatigue. It's pretty cool. So for edema control and improved circulation, a lot of times when people have limited range of motion or limited movement, they get edema in the limb where that's involved. So if you can use electrical stim to contract limb muscles, you can compress veins and lymphatic vessels to promote the flow of fluid from the periphery to the central circulation. It can reduce edema caused by poor peripheral circulation due to lack of motion. When you have edema that is caused by inflammation or organ failure, you really don't want to do electrical stim because there are other reasons for the edema. Also with lymphedema, this isn't going to help. But if you have edema that's caused by lack of motion, here's where you want to use this. So edema due to inflammation, the area is hot, red, and swollen. Sometimes you can use negative polarity, high voltage pulse current to treat that. Usually this is done in a wound care setting, and it's effective. It works. If you have edema due to lack of muscle control, instead of being hot, red, and swollen, the area is often cold, pale, and swollen. And healthy muscles contract to promote fluid return from the periphery. This is what you want to treat with motor level electrical stim and elevation, along with or followed by compression. So these are the settings. This is from the book, of course. You're going to use pulse, biphasic, or Russian protocol. The electrodes are going to be placed on the areas around the main veins draining the area. Pulse duration is in the muscle range, in the motor unit range. Frequency is also in the motor unit range. On-off time, we're going to use a short on-off time Um, 1 on, 2 off, 1 second on, 2 seconds off. Amplitude to produce a small visible muscle contraction, so we don't necessarily need tetany, we just need a little bit of a pumping action. And we're going to do 20 to 30 minutes per session. This elevation here, where the limb elevated above the heart, we are going to use that to gravity assist to the muscle pumping function.